Good afternoon, everyone. I take this opportunity to thank Dr. Hunavar and the Member Scientific Committee of AIOS for this invitation. And I should actually, say that this is the best part of AIOS that I always look forward to, the PG teaching program. So I'm going to deal with the management of blepharoptosis here. So when we talk about ptosis, there are many ptosis. You can have brow ptosis, you can have eyelid ptosis, which is called blepharoptosis, and you can even have lash ptosis. So we are going to specifically deal with blepharoptosis, which is otherwise commonly known as ptosis in our language. As you all know, eyelid plays a major role functionally and aesthetically for the eye. It plays as a protection to the eyeball. If eye is the window to the world and the soul, of course, eyelid is the shutter. If the shutter falls down, there is no light into the eye, and functionally, it can affect the vision. Let's see how. I have no financial disclosures or interests here. It is very, very important on a PG level that you know the eyelid anatomy. I'm sure you all know which are the elevators of the eyelid. Yes, frontalis, levator palpebrae superioris, and Muller's muscle. So how much millimeter of the eyelid is lifted by the levator palpebrae superioris? You have to give me the answer. Approximately 12 millimeters? Well, yeah, approximately it lifts 15 millimeters, levator palpebrae superioris. Muller's muscle, 2 millimeters. And even frontalis muscle has a role of lifting the eyelid for 2 to 4 millimeters. All right, yeah. So this classification is very important even to plan the management of blepharoptosis. It's classified as congenital. This is basically for the postgraduate sitting here. Congenital further classified as simple and complex. And acquired could be aponeurotic, which is very common, acquired aponeurotic ptosis, myogenic, neurogenic, mechanical, and traumatic. So as you all know, it can run in family. There can be a family history of ptosis. These are two siblings who has a ptosis in the family. So family history is also very, very important. So that adds to the fact that ptosis can be familial in a congenital ptosis. All right. I'm sure you have gone through the basics of ptosis evaluation in the morning over here. I'm not going to go into the detail. A quick revision of that. In the history, you have to ask the patient about the age of onset, the mode of onset, laterality of course, diurnal variation, which is very, very important, especially in acquired ptosis, progression, history of trauma, forceps delivery, prior surgery, medications if any, and also periocular and systemic symptoms. This should be useful for you for your practicals as well as your theory. So simple blepharoptosis, the patient has a droopy eyelid, and this is what a simple blepharoptosis is in a child. So what is a very classical feature in a simple blepharoptosis is what you see in the second picture here. What is that? What do you see here? What do you call this? Down gaze, lid lag, right? So on down gaze, there is a lid lag, but this is opposite in the case of acquired ptosis. And why does this happen? Yes? LPS is embryologically poorly developed, so neither it contracts, neither it relaxes, right? So it doesn't pull the eyelid up, neither does it allow the eyelid to come down. And this is very, very classical of a congenital simple blepharoptosis, okay? So this is yet another child where of course you can see the lid crease is well formed, right? So the LPS is good. When in a child who comes to you telling there is a ptosis, first you look is at the lid crease. If the lid crease is present, that indicates that the LPS is not that poor functionally, all right? So this baby has a very mild ptosis with a very good lid crease over there. So this is an extreme case of poor function of the LPS, and this is another case of congenital ptosis with a good LPS. Now we come to the complex blepharoptosis. So what is the diagnosis here? I have two pictures for you here, left and right. What is the diagnosis? Quick, I have only 25 minutes. What do you see here? So the baby has a ptosis in the left eye. The baby doesn't have a ptosis in the other eye. I have not surgically corrected the child. So it's a Marcus gun jaw winking phenomenon in the child, right? You see how the baby has clenched the teeth. Yeah, you feed the baby something in the office and then see whether it's a complex ptosis. So this is a complex Marcus gun jaw winking phenomenon in this child. So yes, we do see patients and even adults coming with this condition. So assessing Marcus gun jaw winking phenomenon and not missing that in the list of evaluation in ptosis is very, very important, because the management drastically changes in this situation. Similar in this case as well. Now, you should always look for the elevation of the eyeball. All right? Why? Function of the? Yeah, easy question. LPS and superior rectus, because it has a common embryological origin. Okay, yeah, so they can have associated monoocular elevation deficiency also. So that's also very, very important. Now, this is a very complex congenital ptosis. All right, so the baby has bilateral congenital ptosis, Marcus gun jaw winking phenomenon in the right eye, and what you see here in the left eye is a monoocular elevation deficiency. So everything is there in this child. So even if it is a baby or a child, you have to take an effort, not complaining that the child is uncooperative, to take down and note all these points, because it needs even a strabismologist intervention at this point of time when the muscles are involved. What is this? Diagnosis. It's written there. Yeah? Blepharophimosis syndrome, right? Yeah. So it's otherwise known as the congenital tetrad syndrome. I always put this slide in my presentation because this came as an essay question for me for my postgraduate exam. I couldn't answer it well. I was not prepared. I didn't know the classification then. After that, in every ptosis presentation of mine, I used to put this for the postgraduates. All right? So blepharophimosis syndrome is also known as congenital tetrad syndrome. It has 4 features, and that is why tetrad: blepharophimosis, ptosis, epicanthus inversus, and telecanthus. It does have a classification also. Depending upon the ovarian function in a patient, it's classified into type 1 and type 2. Primary ovarian failure, type 1. Type 2, no systemic association. And a Callahan classification depending upon the features which is present in these children. Well, so what is the type in this mother? Do you want to classify it? So you have a mother who has a blepharophimosis, who has undergone a surgery. There is a baby again with blepharophimosis syndrome. What type is it? Very easy. I already told you. Type 1 or type 2? 1 with primary ovarian failure. She has a baby in her lap. Right? So it is type 2. No ovarian failure, no systemic association. So she has a type 2 blepharophimosis syndrome. All right. So asking the history, getting to know the parent, everything is very, very important. Even any child, especially a female with blepharophimosis syndrome, we actually evaluate them gynecologically also. All right. This is a very interesting case that came into my practice. This was like many years back. All right. So what is the diagnosis here? Right eye ptosis or left eye ptosis? Yeah? Right eye ptosis, okay. Anything else? Heterochromia, yes. Anything else? Is it seen? Meiosis, correct? Yeah. So she has a meiosis and a heterochromia, all right? So this lady was going to get married, and she said that she wants to get this ptosis corrected. It was a mild ptosis, but then it happened to be a Horner syndrome. So these cases again needs a systemic evaluation. All right, perfect. So preoperative evaluation is very, very important. Before jumping on to advising a surgery to a patient, preoperative evaluation is so very important. You have to look at many, many things: facial asymmetry, head posture, eyelid crease. Frontalis overaction is very, very important again in severe congenital ptosis if you're planning for a frontalis sling, Marcus gun jaw winking phenomenon. already covered, and of course the ptosis measurements, I'm sure it has been covered in the morning. So there are 3 rules that I always never forget. Always rule out pseudotosis. 1, assessment of the best corrected visual acuity, because there can be an associated amblyopia which we don't want to miss as a physician, because that also requires treatment. And the assessment of ocular motility. You can miss many things if you just miss the ocular motility in a ptosis evaluation, which is very important. So this patient came to me, a gentleman, complaining of a ptosis, and he said it is like an acquired. But looking at his features over here, there is no lid crease at all, right? In an acquired ptosis, the lid crease will be present, but it will be higher, right? All of you know that, right? Yes. But this is total absent lid crease, and I didn't believe him. I was like, no, this has to be congenital, so I want to see your pictures. So we often ask the patients before going for a surgery to bring their pictures, the past pictures, series of pictures, to evaluate when the onset was and when did he develop. So he said, no, it is acquired. It was never there when I was a child. I did not trust him. Well, he came up with the pictures. There was no ptosis when he was a child, all right? So this was a case of acquired blepharoptosis where the LPS is really detached, far away from the tarsal attachment, and absolutely no lid crease. So sometimes there can be variation as well, which you have to go back and check, all right? Now going on to the management of blepharoptosis, there are certain things that we consider before, again, as surgeons, we jump into the management. The risk of amblyopia has to be assessed, especially in children. There are situations where the ptosis will be mild. You don't have to really take it up as an urgent case for a ptosis surgery. You can still wait if there is no risk. Functional vision is very important, especially in these old patients who have an acquired aponeurotic ptosis. They get their cataract surgery done, but they have this aponeurotic ptosis which is never addressed, and the vision is still there, not good, right? So the eyelid is, in this patient, as you can see here, it's completely covering the pupillary axis, and at certain times when the patient is tired, even the other pupil is covered. So as a cataract surgeon, you should also be aware of the fact that after giving them a good IOL inside, whether the shutter of the eye is also working properly. So they might require an aponeurotic ptosis repair. So it's very important. Function is very important. There are patients who actually doesn't have, because of the severe ptosis, they may not have the field of vision in this laterally. So all these things has to be is a concern. Now next is a cosmetic concern. Most of these patients come during their 20s, early 20s, late 20s, when they are going to get married and they want a cosmetic reformation and aesthetic improvement of their face. So surgical management of blepharoptosis depends upon the type, the severity, most important, the Levator palpebrae superioris action, and I also consider Bell's phenomenon before I take a decision. So these are the list of surgeries depending upon the severity that we do consider. I'm sure Dr. Grover also agrees to it. Mullerectomy or fascinella serrata, LPS reattachment or resection, supramaximal LPS resection, Wicknall sling, and tarsofrontal sling. Now this depends upon how severe the ptosis is. In mild ptosis, we often go and do mullerectomy or fascinella serrata. Moderate, LPS reattachment or resection, and in severe, these are the surgeries that we often prefer. Now what do you mean by this severity of the ptosis? So basically, depending upon the palpebral fissure height and where the eyelid is situated and the Levator palpebrae superioris action, this is how we assess. So according to the Beard's method, the father of ptosis, who have taught us many surgeries and many numbers and rules in the ptosis surgeries, depending upon the pupil, it's considered mild if the eyelid stays at the upper border of the pupil, moderate if it is in the middle, and severe if it is in the lower border of the pupil, all right? Depending upon the LPS action, it's very important for you for your exam, and this is sure do that your examiner will ask you about this. Poor if it is less than 4 millimeter, fair 4 to 6 millimeter, good 7 to 10 millimeters, and excellent more than 10 millimeters. I'm sure you can go back and read the theory. So this was, well, yeah, you can see here. What is this? Mild ptosis of the left eye. And why have I put this here? You know the phenylephrine test, right? Yeah. Yes? You know that, yeah. So in mild ptosis, we actually do a phenylephrine test in order to assess what kind of surgery we would want to go ahead in order to know the action of the Muller's muscle. Alright, yeah, so you can see how well it's corrected after the phenylephrine test, and this patient underwent a Mullerectomy of the left eye. Alright, so this is a baby with a congenital ptosis, but as you can see here, the lid crease is quite prominent, very mild ptosis, although it was congenital, who required only an LPS resection of the eye. Alright, yet another case, a little bit more severe as far as the palpebral fissure height is concerned, but he still has a lid crease, so an extended levator resection was done in the left eye and he was corrected. Now, this was a young lady who came to me complaining of ptosis in the left eye. But if you actually see her, she does have a very mild ptosis in the right eye also. But she was just not willing to undergo a surgery for the right eye. So it was quite challenging because you have to kind of, in order to symmetrize, you have to give an undercorrection of the ptosis correction that you're doing. And that's exactly what she received here. And even in this eye, she has a very high lid crease. So it's very, very difficult to give a high lid crease when you're actually attaching the levator palpebrae superioris. A little bit of here and there adjustment and she gets a good correction. So levator palpebrae resection and reattachment, I'm just not going into the theory, but I'm sure you all know that. So basically you enter through the skin, you identify the septum. When you open the septum, you see this fat, the preseptal, the postseptal, retroseptal fat pad, and just behind the fat will be the levator palpebrae superioris. Okay, so you expose the levator palpebrae superioris, then you come to the tarsus, you detach the levator palpebrae superioris from the tarsus, and then finally, depending upon how much height you want, depending upon the measurement, on table, you actually stitch the levator palpebrae superioris onto the anterior edge of the superior border of the tarsus, in the center, medially and laterally. Alright, so this was a very interesting case that I want to show you. So this patient came with a ptosis in the left eye. He says, I have ptosis in the left eye, a Chinese patient. What do you think? Just left eye? Yeah? What would you tell him if you saw this patient? Yeah, I told him he has a ptosis in the right eye also, a mild ptosis in the right eye. And in fact, I tried to convince him, you know, we might have to do both the eyes, but he's like, no, only the right eye. And why did I convince him? I tried to convince because there is something called the Herring's law. All of you know, right? Yeah. So when you lift the worse eye, the other eyelid can droop. So all these patients who have a mild ptosis in a, in one eye and severe ptosis in the other eye, you should always tell them preoperatively that this is what is going to happen to you, and he never listened to me. All right. So this is 2 weeks post-operative. All right. So you can see this is corrected and this has further dropped. So then he went for the surgery of the right eye also. Sorry, this is 6 weeks post-operatively, which has further dropped. Okay, 2 weeks, 6 weeks, it has further dropped. Then he went for the ptosis surgery of the right eye also. So Herring's law plays a major role in bilateral asymmetric ptosis, which has to be discussed with the patients. Now in older patients like this, he has an aponeurotic ptosis. As you can see here, left eye more than the right eye. And there are many other things which has happened in the periocular area over here. He has a dermatochalasis, all right? Severe dermatochalasis in the right eye. If I lift that up, there is going to be a hooding of the skin, and that can even affect the vision and the field of vision laterally in this case. So there are situations in older patients where we combine ptosis surgery with other periocular surgeries as well. What did I choose? I chose to do an LPS resection with a blepharoplasty in both the eyes in this patient, and the patient is happy. Otherwise, you lift the eyelid and then the dermatochalasis will start hanging down and it's not going to benefit the patient. Yet another patient, a male patient bilateral, you can see he has also got a brow ptosis. He has a ptosis, dermatochalasis and a brow ptosis over here. So a mixture and a combination of LPS resection, blepharoplasty and brow pexy was done in this case. So this was again a case of congenital ptosis, severe. His LPS action was less than 3 millimeters. So I used to do a lot of frontalis sling surgeries earlier, but I'm gradually shifting to the supramaximal resection of LPS in these cases because cosmetically it looks slightly better and in a long term a better outcome than frontalis sling surgery, and this is what the patient underwent. Whitnall sling surgery, again in severe ptosis, you do, and she actually received a lid crease formation also, an artificially created lid crease over there. Tarsofrontalis sling, yes, we do in severe ptosis where the LPS action is very, very poor. I have experience with silicone sling, but Dr. Grover has done a lot of fascia lata. Silicone sling, yes, it works. We can also do a readjustment if it is required later. And this is a patient who has undergone a tarsofrontal sling. So how many minutes more do I have? Last minute. Okay, so I'm going to skip this video of that. So severe ptosis is frontalis sling surgery. Marcus gun jaw winking phenomenon, what we do is we resect the LPS because there is a winking which is associated with the jaw movement. So you want to actually abolish the movement of the overaction of the LPS. So LPS is resected and then we give a frontalis sling in these cases. Blepharophimosis syndrome, medial and lateral canthoplasty is done along with frontalis sling surgery, and this is a child who has received a medial and lateral canthoplasty with frontalis sling surgery in blepharophimosis. A small baby with blepharophimosis syndrome, when you want to avoid the risk of amblyopia, we give them a temporary tarsofrontal sling, and this was done with an ethibond suture, a 3-0 ethibond suture, a small elevation of the small eyelid, and this is how the child is after the surgery. There can be situation like neurofibromatosis with causing a mechanical ptosis, as in this case. She has got cafe au lait spots, and what we did was excision of the levator LPS, resect maximum, and then gave a LPS resection. So in such cases where there is bilateral involvement of this massive neurofibromatosis, she has got a severe ptosis of the left eye and a ptosis of the other eye with this lesion over here. She received a debulking, facelift, internal brow fixation on the right side, debulking and tarsofrontal sling on the left side. So we need a lot of combination. This is a 68-year-old lady with droopy eyelid and diplopia. A old lady presenting with diplopia, what is the first thing that you would think of with ptosis? Myasthenia gravis. Okay, eyes test is very sensitive. Then you do the edrophonium or the neostigmine test, and she was positive for that, so it was an ocular myasthenia. What about a small young patient, a 20-year-old male with progressive droopy eyelid, and he has ocular motility limitation also? What would you think of? CPEO, chronic progressive external ophthalmoplegia. How do you confirm it? Muscle biopsy, all right? Ragged red fibers, and it's very, very important when you're suspecting a CPEO. This is a 23-year-old male with road traffic accident. What he has is, I'm finishing, sir, maybe 30 seconds, proptosis, total loss of vision, complete ptosis, ocular motility limitation, and he has a bruit. Okay, so this was a case of an arteriovenous fistula involving the internal carotid artery in this patient. He underwent all these interventional vascular surgeries with clipping, etc. of the arteries, and still he had a complete ptosis. So in traumatic cases, we don't again jump into surgeries, we wait. And this is after 4 months, doing nothing, observation, all right? So trauma, you're always justified to wait from 6 months to 1 year. And this is a very important case that I want to point out. A 54-year-old lady who was referred to me for a ptosis. I felt it's more than ptosis. There is fullness in the upper eyelid also, all right? This was a case of a Tcell lymphoma, a high-grade Tcell lymphoma in a patient who was referred for a case of ptosis. So you should be aware of all the differential diagnosis. You should be aware of evaluation, and this is how you take a correct decision in the management of these patients. So for me, etiology definitely tells me what decision that I should be taking, and surgical management definitely depends upon type and severity, and amblyopia treatment has to be taken care, if at all, if it is present. Thank you very much for your patient listening.
Thank you, Dr. Fairooz. So now that